Thank you. Colleagues from Autism Speaks and the members of SLACD. First of all, thank you very much for inviting me for presenting the national level plans for autism in Sri Lanka. Now what I am going to present is a result of a presidential subcommittee. Essentially the president has established a subcommittee for autism in about say 1.5 years back, where he asked 4 ministers, Minister of Health, Minister of Education, and Minister of Social Welfare, and the Minister of Women and Children to come out with proposals for autism. And in that, the follow-up meetings, so we have recognized that the different roles of the different ministries could be age-based. For example, in Sri Lankan setup, up to 5 years, the ministry which is in contact with children, mostly the health, others will come to play later. So my actions, so the plans that I will be describing will be limited to 5 years. Because thereafter, this total plan is going up to more advanced years, but in place of different ministries. So, now in fact, in the Ministry of Health, we do not like to recognize autism as a separate program. We would like to look at it as a component of the national special need program. Now when you look at that diagram, you can see that our special need, the child development and special need program has 3-pronged approach, where we consider promotion of growth and development of normal children in one way, and there is a screening for developmental issues and care for children with special need. So we have 3-pronged approach. So now our autism care is being integrated into this overall program, not as a separate vertical autism program. So we will be talking about how we screen these children and how we confirm whether they are having the problem and how to provide care. Now these are the plans we are now currently in the progress of implementing. Now this is a quite complex issue, so therefore let me try to discuss it one by one. Now, if you take a child with autism, so that's say from birth to 5 years, along that, so we, now this particular this area within the square will be where I will be focusing on how to screen them, and then above that how we are going to provide care. Now we are, in terms of screening or identifying potential children, we are thinking about two-pronged approach, where we think of parents and also we think of our primary health care workers as the stakeholders in identifying children. So we are proposing a screening of all the children who are at risk or the high risk conditions, for all the special need conditions and also for autism as well. And then we are now planning to ensure all the children are being screened at 9 months, 18 months and 3 years, and before school entry 5 years of age. So that if we have a certain system in place, every child will have 4 or 5 opportunities of getting screened by a trained private healthcare worker. So it involves a lot of work, training, tools and so many other things, but this is the framework. And then, now for the parents, all the children in Sri Lanka will get what is called a child health developmental record at birth. Because about 99% of our children are born in a government health institution, and they will get a CHDR, and also those who are not getting that also will receive it in the field. And then in that we have included child developmental indicators for parents to monitor. And also now I will be explaining later, we have a program to enhance the capacity of parents of using these tools and also getting their children screened by themselves. Now primary healthcare workers, which I will be explaining later also, we will be trained to do this mandatory screening of their target group children once they come through their ages. And then now those who are screened and found to have certain developmental concerns before 18 or 2 years before, we are hoping to direct them to what is called the parent-mediated non-specific interventions. And also after that, if say beyond 3 years, you can see that there are two colored arrows where there is a normal developmental screening. Those who are found to have problems after the developmental screening will be offered a specific developmental screening for other developmental conditions, maybe autism, maybe cerebral palsy, that we are going to pilot and identify and decide. So that if they are positive for both, so they will be having some form of diagnosis and they will be offered specific interventions. In order to offer these two types of interventions, we are proposing two institutional arrangements. One is called the Primary Child Developmental Center and one is called the Secondary Child Developmental Center. So those are the basic blueprint of what we are trying to achieve through this proposal that we are providing to the government. Now let me further explain this. Now how many children are we talking about? Now can you remember that Honorable Minister was talking about? Now in the total schools in Sri Lanka, we still have about less than 9,000 children for all different special need conditions. Now we have a 375,000 birth cohort every year, somewhere there. So that means if we are going for 1% average prevalence of autism, we are talking about 3,750 children cohort of autism will be, they will be born. But they will be identified later, but every year we produce 3,700 children with autism. And we have a under 5 cohort of 1.85 million. That means we are talking about, at the same prevalence level, 18,500 children with autism. Even today we expect to have such a large number of children in the country. And when you talk about school population, it's about 3 million. That means we are talking about 30,000 children with autism in school age. You can see that only 9,000 is identified in the school system for all different conditions. So we are totally nowhere at the moment. So this is our target group. So this is the amount of care we are thinking about, the burden of providing care for these children. Now, for our visitors' sake, I thought of just elaborating on our health system as well. Anu has touched on this. But if you look at this diagram carefully, we have two parallel health systems in this country, which is kind of unique when you compare to the other countries. We have a curative health system. We have a parallel preventive healthcare system. In the curative health system, we have a primary healthcare hospitals, secondary healthcare hospitals, and the tertiary healthcare hospital like this one. Now, when you look at the primary care hospitals, so this primary or divisional level is being divided into 330 sub-areas in the country. So you know these DMO stations, now we have some, for each small area called MOH area, we have 1 or 2 primary level divisional hospitals. And we have, by district level, we have secondary care hospitals. If you take, say, Kurunegala districts, we have Kurunegala General, we have Puliapitiya. So likewise, we have a specialized hospital for districts. And then we have a very highly specialized hospital like LRH and also National Hospital Colombo, where we have all different types of facilities where, so we are supposed to have a referral system where the primary cases are going to the local hospitals and then the new ones are being referred up. But it is not a rule here. Anybody, even from the field also, can directly come to a national hospital as well. Now, this is the usual system in many countries, but when you look at the preventive healthcare system, we have a very unique health division, a team of primary healthcare workers assembled into a MOH team. Where we have 330 MOH areas in the country at a primary level, delivering various preventive and promotive healthcare services. So under which the maternal and child health program is also one of the programs implemented by the medical officer of health and his team of public health midwives and public health inspectors. So that's an overall teamwork. Now they are being supported by central and regional level bodies, the central technical bodies like so many, but the way I come from Family Health Bureau, then there are epidemiology unit, so there are so many other central campaign programs. So now we are going to introduce this autism care or the special need care into these places in this system. Now in the MOI system, basically we'll have a screening role as well as follow-up role and also parent counseling, that sort of thing. Whereas we are trying to introduce primary child development centers at primary level and what is called the secondary child development center at regional level. So one primary child development center per MOH, and so that will be, we are talking about 330 such units per country. And whereas one or two secondary child developmental centers at district level, for highly populated districts, more than one secondary child development center, but for the remote districts, one may be enough. So we are talking about roughly about 40, altogether 40 secondary child developmental centers. So that is where, and also at central level, kind of a steering body at the ministerial level, Family Health Bureau and Ministry of Health, to oversee this or steer this program. So that is basically where we are trying to fit into the national health system. Now, it is important to understand this MOH system in order to understand what I am going to say later. Now, in this country we have about 330 such small MOH areas, where each division will have a team of workers headed by a medical officer and public health midwives and then public health inspectors, and there are others, but those are the main people. Usually the population of this unit has to be responsible varies. Some in the very remote areas it may be around 60,000. In a kind of urban areas it may be 150,000 to 150,000. Now, basing on that population, say if it is 60,000, we are talking about 900 annual births, and that is about 75 monthly births. So we are talking about roughly around 20 public health midwives. That means 4 births per a midwife per a month. And under that population we have about 4,500 children under 5. So if we are talking about the populated MOH, 150,000, we are talking about 11,250 under 5 children, where still the midwife will have average number of 4 to 5 births. So because we are increasing the number of midwives in such areas to ensure that she is having a manageable number of people. So that means we are talking about in a MOH area 9 to 25 autism cohort per year. And if the identification is after 2 years, hopefully, we are talking about 27 to 66 children who are living in that area within preschool years, 3 to 5 years of age. And we are talking about children of 450 to 1,100 children with special need, assuming 10% prevalence for all the developmental disorders, which is, I know, is very low, but to be very conservative. And we are talking about 300 to 750 screening load for a primary healthcare system for a MOH area. So for a MOH has to screen about 300 children for. Now that means 20. Now the screening load for 20 children per month for a public health midwife. I will show that how we arrive at this number later. And about 30 to 75 children for a medical officer of health to screen per month. But I put within bracket this 75 because when we are having 75 children, most of the time we have more than one MOH working in the field, so that the number will be more or less 30. So referrals from the MOH would be 9 to 22 children per year, whereas say 0.75 to 1.9 per month. So it's basically 1 to 2 children per month from a MOH area. Okay, now we have some understanding about how many children we are talking about. Now, promotion of growth development, which is not relevant, I am not going to talk about it. But there, I would like to say that in this program, we are empowering mothers to understand the common developmental disorders and how to monitor their development in order to be able to spot them and to be referred in a safe manner to a MOH. Now, so screening and assessment. How are we going to achieve the screening and assessment? Now, aim is to screen the children at birth and also 9 months, 18 months and 36 months by a primary health care worker. Now, parent screening is a regular thing, so that if they find out an issue, parents are supposed to inform the area midwife. So that access is there, especially in the rural areas, it is very much so. And then, considering the annual, say that monthly births for a midwife, we can estimate about, every month, she has 5 children who are passing their 9th month, another 5 children passing their 18th month. Likewise, every month they have children passing that particular month. So that means she has to screen, if she is focusing on these 4 points, she has to focus only 20 children per a month, whereas she has about 150 under 5 children under her care for that month, but she has to organize her work in such a way that she identifies these children and try to screen them. So this involves a lot of work. We have to identify sensitive and specific enough tools here, so that train them to do that and to establish a system where these children are, once they are being identified, screen positive, to be referred to the MOH in that particular area, where he is supposed to help the older, but it's called the child development clinic once or twice a year, so not twice a month. And then, now one MOH will have about 20 to 40 midwives depending on the population size. So we estimate, so these referrals, now not all 20 children screened by public health midwife will have problems, because those are normal children, all the children she is screening. So we calculated about 30 to 75 children depending on the population MOH will get per month. So MOH will again be, we are planning to train MOHs to cater for this need, to provide them with certain diagnostic skills. Once both of them, primary health care workers, public health midwives and the MOH is satisfied that she is potentially having a problem, the child, then we are planning to send that child to what is called the secondary child development center, where we try to organize this institution ideally to be headed by a developmental pediatrician or a community pediatrician and visited by a child psychiatrist, and we'll have a routine staff of speech therapist, occupational therapist and a physiotherapist. So it's a kind of a specialized center we are talking about, which will be erected at district regional level, where the MOHs can refer these children to the area secondary child developmental center. Once the child is being sent there, the child is assessed, and then we have to come up with the protocols there. So they diagnose, confirm and establish management plan, and then refer them back to the primary child development center, which one will be set for a MOH area from which the child has come. So that is the idea, because if we are trying to hold them at the regional level, so that's a lot of travel time, lot of people, and in fact we will have to have a hospital like this size for a district to manage only the child developmental disorder. So therefore we thought of getting them to do a specialized work and to confirm the diagnosis, draw up the management plan, and to advise how to do that and send them back to the primary child development center, which will be set in the medical officer of health area. So we have again identified each such center will have about 250 children with developmental disorders under its care. Once it is been fully functional, where about 20 to 30 children will be attending these centers regularly. So it is going to be a fully loaded work. Now we are considering about who will be the staff there. There is no issue. It should be a specialized center. Now, in my view, I think this also should have at least occupational therapist and a speech therapist, and then specialists from this center, secondary center, can once in a way visit these centers for supervision. But at the moment, we are having difference of opinion about who will be put there, but that will be sorted out soon. So this is basically how we screen. We get parents to screen, and we get public health midwives to systematically cover all the population, child population at 4 points in life, and then MOH to establish the suspicion made by the public health midwife, and then refer them to specialized center. So that is the basic arrangement of this proposal. So special need care. Now it's again same thing. Now we are trying to, the children will be at home, at clinics, at preschool. So screening programs will be set in several places, set in place, so that children will be screened. Identified children will be referred to the medical officer of health. He will establish the suspicion, and if both are okay, they will be sent to the secondary child development center. From that center, child will be referred back to the primary child development center, so that it will be a process of care. Now it's again the same thing in a different format. Right. So that we have seen that arrangement will be fit into these places in our health system. So far, what has happened? So this model has been accepted as a policy by the Minister of Health. And Secretary of Health has requested us to initiate a pilot project on this, involving 6 MOH areas to see how it goes, and to come out with protocols and so many other things. And in fact, the grant has been earmarked for the one province, which involves about 35 MOH, which is about 1/10 of MOH areas of the country, by the Treasury, and that we came to know that the Korean grant has been approved by this last budget. So it will be, I think, most probably will be materialized. So if it is materialized, that these other things will be moving forward to the Western province initially, so later to the others. So a lot of things as an unfinished agenda. Now, so far the project proposal has been, concept has been accepted, the policy decision has been made, fund mobilization in the sense has been approved, like. So now we have to think of training, staff allocation, then the guidelines, then the capacity building. Then of course the most difficult thing is new infrastructure. We have to think of how to build up these secondary child development centers and primary child development center. It's a huge issue in the sense that it's a formidable task to be done. And then finally, MOHs and the people in these primary child development centers and secondary child development will do the work. And then we have to later and concurrently evaluate and see whether this program is working as it is expected, and to see certain changes. So in this we have a lot of players: the Family Health Bureau, Ministry of Health, regional directors, provincial directors, then the Directorate of Youth and Disability, and then the Training Institute, Director Training, and the Lady Ridgeway Hospital, government sector, and the University Autism sector. so there are these color code is all of these people are involved at different places for doing different things. So that is the plan in brief what we are trying to do. I think you will have seen the detailed plan as a soft copy. So that is what we are hopefully planning to achieve. I hope that it will be